Hi, I'm Dr. Dan Cox, a professor of counseling psychology at the University of British Columbia, and welcome to Psychotherapy and Applied Psychology, where we explore practical insights with leading experts. Today, I'm thrilled to welcome Dr. Bryan, a world authority on suicide prevention. In our conversation, we discuss critiques of some approaches to suicide prevention, understanding suicide as a health behavior, crisis response planning, means restriction counseling, motivational interviewing, and much more. Please leave a comment below, and if you enjoy this conversation, it would be very much appreciated if you hit the like button and subscribe to the channel. This episode starts with my guest responding to my question about how we got into studying suicide. Let's jump in.
Yeah, when I was in graduate school, guess I started like over 20 years ago now. I went to Baylor University, and my director of clinical training was David Rudd, who's a very prominent suicide prevention researcher, and so was fortunate enough to learn a lot from him and to study under him. And towards the end of my psychology training, I, enlisted in the Air Force, joined the military, served as a clinical psychologist at that time. And that, just so happened to kind of correspond with the time when suicides in the U.S. military started to increase. And so there was sort of this kind of convergence of timing with, this training experience, mentorship that I had received from, a suicide prevention researcher. And so that I think really kind of came together and cemented my interest in suicide prevention. And then I would say the last key moment was as part of serving in the military. I deployed to Iraq in 2009, and it was while I was overseas that I, really came face to face with the reality of suicide. And that's because, when service members, when others would kill themselves, they were brought to our hospital, and we would, take care of their bodies, keep them functioning so that we could transport them home and do organ donation, things like that. And so it was the first time that I had seen dead bodies like that, and it really changed my, I think, understanding of what suicide is, and especially because in that setting, pretty much all the suicides were self-inflicted gunshot wound, and so that really, I think, kind of exposed me to the brutality that can be suicide. And so it was very different from how I'd thought about it. Was kind of experiencing it for as a outpatient behavioral health provider. You don't really see those things on a regular basis, and so yeah, so that those were kind of, I think, the three things, and within the span of maybe about 5 or 6 years, that really made a difference and pushed me down this track.
What was it about the brutality that, I don't know, it makes it become real, but like, what was that sort of pushed you, if that makes sense?
Yeah, I think I've shared this story, one particular story from my deployment, where we had a week, um, basically where there was a sandstorm, and so all the flights were grounded. And usually when, a suicide case was brought to us, they arrived, we stuck them on the ICU, we took care of them. And then usually overnight, they were on a plane to Germany, and then from Germany they would come back to the U.S. Um, and so because of this sandstorm, however, all the flights were grounded, and we had three suicides in the unit at the same time, and they were with us for several days. And so we put them next to each other in the ICU to make it easier to monitor them. And I think it was just that prolonged nature of having these soldiers with us on the unit that it definitely had a psychological impact on the entire hospital staff. And it had an impact on me as well. And so just not seeing, what sort of the consequences of this exposure to suicide was on other medical providers. But I do remember one day in particular standing at, the foot of the beds of these three soldiers, and just really questioning a lot of, our assumptions about suicide. That was really, in many respects, the origins of a lot of my critiques of the field. Because for whatever reason, that was a moment that really kind of stood out to me. Like, man, we're really bad at this, and I do think there was something about the fact that it was self-inflicted gunshot wounds, and in all cases it was to the head, and so you just, even though they had been cleaned up and taken care of, I mean, it's very brutal, it's incredibly violent. It is not, I think, sometimes there's, I think, an impression of it's almost like a peaceful sort of death
Mm,
because we think of
mm.
overdosing or something like that, and it isn't that at all. And yeah, it definitely changed things for me.
What were your critiques of the field that sort of became apparent at the time?
I think it really started with a very non-specific question, which I mentioned before. It's like, why are we not better at this? And
Right.
what are we doing wrong? It was also while I was deployed that I, aside from those three cases, were just confronted with other cases that really defied a lot of what I'd been taught about
Mm,
suicide. And in particular, one of the areas that I speak about a lot now is the purported role of mental illness as a cause of suicide. And it was just over and over again. I was evaluating people in the emergency department who had survived suicide attempts, hearing stories, from you know, peers, friends, unit members of those who had died, where it was like there just wasn't any sign or any evidence of mental illness. And I think of another case I've talked about quite a bit of a Marine that I evaluated, who had tried to shoot himself and missed. I don't know if it was by luck or what, but had a laceration on his chin, gunpowder all down his neck. And, I spent at least an hour, hour and a half with him, and there was no mental illness. There's no depression. There's no anxiety. Um, he didn't have any relationship problems back home, no financial strain. It was sort of like, in many respects, he had this clean bill of health. And it was just like, what the hell happened? And he couldn't make heads or tails of it either. It's like, I don't know. It just kind of happened. And I remember, I signed the paperwork to send him to Germany. It's like, man, you're not staying here in a combat zone where everybody's packing heat. And he spent a week on the inpatient unit at the Army Hospital in Germany. And during our weekly consultation calls, where those of us in theater would, coordinate care with, Germany, um, it, I remember they were presenting the case and they were like, "What's going on with this guy? We're missing something." And I'm like, "Well, I was hoping." I was like, "He's been with you for a week. I was hoping you would tell me what's going on." And this was just happening over and over again. And it really, I think those were the first major questions that I had, was surrounding, again, this assumed role of mental illness and maybe suicide and suicidal behavior. Maybe there are other pathways that people follow, or maybe there's something else beyond. It's not only mental illness, but maybe there's something bigger that's happening.
So, how have you come to understand that or make sense of that?
Yeah, I found it helpful to think about suicide, is in essence, it's a behavior. And actually, Rory O'Connor, another suicide researcher in the UK, has framed it in his book as a health behavior, similar to like smoking or substance use or sexual behavior, things like that. And I found that incredibly useful to think of that way because it is a choice, it's a decision that people make that impacts, mortality, well-being, so on and so forth. But it kind of, I think, unmoors the act itself from this sort of box of mental illness, in the same way that we know things like substance use and smoking, other potentially harmful behaviors are correlated with mental illness. but it's not always caused by it. It's not the same thing as mental illness. And I found that to be a really useful way of thinking about it. And even within my clinical work, as we think about treatments, approaching it from the perspective of it's a decision, it's a choice that people make in certain states of mind or under certain circumstances. And if we think of it that way and approach it that way, then it really, I think, kind of shifts how we approach suicide prevention. How do we identify people? How do we help them? And how do we potentially prevent this behavior from occurring? I'll say one other, one other, I guess, kind of thing or question that I've had as well that I would say, ties back to those experiences in Iraq was really thinking very hard about how most of our work around suicide prevention has been largely driven by the question, why do people kill themselves, or why do people die by suicide? And as a clinician, I found it to be much more useful to ask a slightly inverted question, which is, why do people choose to live despite wanting to kill themselves? Because really, when it comes to like treatment and prevention and things like that, it's what we're trying to do is like kind of stop that forward momentum. And so it's kind of like I'm not as necessarily concerned about why you are racing towards that brick wall. I just want you to stop or change course or something like that. And I started thinking a lot about how, in vehicles, whether it's our cars, but, trains, other things like that, the accelerator is different from the brake, and they're totally different systems. And so how you move forward and how you stop involve different processes. And again, kind of thinking of it that way, of the decision to hit the brakes might be very different from whatever it is that's propelling you towards suicide. So yeah, and so that the treatments and interventions that we've designed have really been, I think, kind of motivated by this idea of a braking system, an internal braking system that people have to find and they have to be able to use.
Okay, so you've said a lot. I feel like I'm going to fail in terms like I think there are many roads I sort of want to go down, but we'll make choices and some of them will be wrong, but that's okay. One of the things I just heard you say is that there are two mechanisms or two ways that a therapist can think about intervening with a person. And what I heard you say, sort of follow your metaphor, is often we think about the gas and doing the gas is the motivators for wanting to die, that we often think about how can we help people take their foot off of the accelerator, but there's a second system that we also have the opportunity to engage in, which is the reasons for living and whatever language you want to use there. And so then that also gives us an opportunity to intervene with helping them put on the brake.
That's right. Yeah. Yeah. And I think, I would say some of my thinking around this has, again, I'm always trying to find like metaphors or
Yeah.
examples outside of behavioral health of how can we understand this? And I've found that to be an incredibly insightful exercise to engage in, where it's like, how do other disciplines do this? Or where else in life is there some sort of lesson to be learned here? And and that, I don't know how or when I kind of came across that idea of like the braking system different from the accelerator, but it definitely has made a big difference in how I work with my patients who are suicidal. It's also helped me to, I think, kind of view what's like, well, why, in essence, why are we not better at this? Well, I think it's because we're mostly kind of thinking about taking our foot off the accelerator. And maybe we just need to completely change or look at other processes that are independent of those drivers towards suicide.
Right. Well, and I'm thinking as you're talking, regardless of if we should, go through door number one or door number two, the accelerator or the brake, it sort of opens up a second lane, a second, a second opportunity there for therapists who might be really struggling with a client to then to reframe the question
Yeah,
as you did and be like, oh, maybe this is maybe I'm hitting the wall with this client this way. Here's another way I can try it, right? As they're
yeah,
grasping to try to help their client.
yeah, yeah, absolutely. And I've certainly I've been in that position myself as a clinician plenty of times where it's sometimes hard. People are really stuck in life, and sometimes it's because of maybe their own histories of whether it is their own struggles over the course of life, but oftentimes it's the conditions that they're in as well, life circumstances. And if we kind of focus only on removing those drivers, or in some cases, it's just like completely out of our control. And so I've kind of learned with patients, like I can't increase the size of your paycheck, and I'm unable to address, you know, all of these social determinants of health. And so, given that in some respects we're kind of stuck with these circumstances, what are we going to do? And so it's like, okay, well then let's find the braking system, because there might be all these reasons for why you believe you should die, or it's logical to die, um, but there are also these reasons to not do it. And so let's also think about those, because if there's one thing I've learned doing this for 20 years as a clinician, it's like people who have nothing to live for don't come to clinicians and say, I'm thinking about killing myself. And so something is holding you back, and something is kind of tethering you to life. And perhaps let's just talk about that, even though there's all this chaos and distress and despair going on as well.
I think that this conversation is a good lead in to talking about crisis response planning, which is an intervention that you've developed. I'm wondering if you could sort of start us off by just giving a broad overview of that.
Yeah. So crisis response planning, and I would say now, kind of the way we use the term, it's often referred to like this procedure that we will use with suicidal individuals or vulnerable individuals. It's maybe like 30 minutes that it sometimes takes to complete one of these plans. But the origins of crisis response planning go back, decades. You could find the first hints of it in dialectical behavior therapy, or DBT, where Marshall Linehan kind of outlined, when you're on the phone with a really high risk person who's in crisis and you're coaching them, there are kind of these steps to follow to help a person get through those urges to kill themselves. And she called them crisis response procedures. And then later on, David Rudd took those ideas and he kind of formalized it within cognitive behavioral therapies for suicide prevention as a thing we could do in therapy to help people in between sessions when we're not available. How does a patient self-regulate when they feel like they're on the edge? And then later on, what we did is we said, well, hey, we're doing these. A lot of us are working in primary care settings or emergency departments or crisis call centers, where you may only have that one opportunity to intervene with someone, and there perhaps is no expectation of an ongoing therapeutic relationship or treatment relationship. And so if you have 30 minutes or an hour with someone, like, what's the best way to spend that time? And so we took this idea of crisis response planning out of these psychotherapies, and we said, well, let's start doing it as a standalone intervention. And that was, sort of born out of a necessity, because in my early career, the first clinical setting I worked in was primary care. I had 20-minute appointments, 15 to 20 patients a day. It was high volume, low intensity. And when I was working with someone who was highly acutely suicidal, I did not have the luxury of hour-long therapy sessions and let's meet once a week forever. And so we started to kind of tinker with this concept, and lo and behold, what we found is that it worked. And basically, there's a few steps involved in this procedure. The first of which is, you know, uh, eliciting the suicidal individual's narrative, their story. And so we ask people, tell us what your suicidal experience is like. You know, maybe you recently attempted suicide. Tell me the story of your suicide attempt. Or maybe there's a day in the past few weeks where you just really wanted to die. Tell me about that day. How'd you get from like point A to point B? And as that story unfolds, it helps us to kind of understand how and why is this person sort of in this context and in this space. And then we can use that information and the trust that it builds with the suicidal individual to then come up with these concrete steps where we first start with how would you know that you're heading towards this before you get to the crisis? What are the warning signs? And then once we know how to identify when you're on that pathway, what are some things that you can do to feel better, to distract yourself, or to somehow change course? And so there's self-management strategies. And then we talk with them about their reasons for living. What are those sources of purpose and meaning, the good things in life that hold you on, keep you here and help you wake up in the morning? And then there might be people that you can reach out to who are supportive and helpful, whether you just call and chit chat with them or you get actual crisis support from them. And then the final step is professional crisis services. So how do you get the professionals involved at that point if all else fails? And a big piece of crisis response planning that we are now very clearly understanding in our research is that customization and personalization matter a lot. And so it's really helping an individual through their personal narrative to discover and recognize what are the very specific things that I can do that perhaps might be different from what you might do or what anybody else may do. But this sort of and it's like 6 or 7 steps, something like that. Like I said, you can typically do it in less than 30 minutes. We've shown, significantly reduces suicide attempts by 50% up to 76%. So it's remarkably effective considering how simple in some respects the intervention is.
And it sounds like what you're saying is it requires sort of in that brief intervention uh, a notable amount of depth by the therapist to facilitate by the, I want to say therapist, but it could be obviously not a
Mm-hmm.
psychologist or whatever, but by the helper to understand and to personalize the plan.
That's right. Yeah. Yeah. So when we're teaching clinicians, but also non-healthcare providers, we do trainings for peers, teachers, faith leaders. It's really we kind of conceptualize it as
Mm-hmm.
being very similar to kind of like CPR. Most of us are not physicians or surgeons or nurses, but if we see someone collapse around us, we might have received training on how to keep that person alive and to help them until the paramedics show up, right? And so I think of crisis response planning in a very similar way for non-healthcare providers. And we really emphasize this notion of spending time with the person to help personalize and tailor such that if someone says, for example, something that I do that helps me feel better as I listen to music, and typically my follow-up question is, well, what's your favorite music artist? What type of music do you listen to? And are there some types of music that are reliably helpful, but maybe there are other types of music that are not helpful? And so how do we make sure that we're that specific so that in that crisis moment when you're having a hard time kind of making decisions, you just follow the instructions and it's much more likely to be
Mm-hmm.
successful.
One of the challenges that I see that is that clinicians always feel a lot of pressure in those moments and are sort of, I guess what I want to ask is, how have you found to help folks not engage in this in kind of a checkboxy kind of a way? Does that make sense?
Yeah, it does. It is. I mean, it's one of my biggest concerns actually of what's happening within the field is that um, we are moving to these checklist-based approaches that are very compliance-oriented, and the a lot of the rationale for developing standardized forms and checklists, fill in the blank types of things has been well intentioned, right? It's sort of
Mhm.
like, here, this is a memory aid. Here's what to do. Don't forget these different steps. But I think what what has often occurred is that the form, the checklist is then provided to people without the context of how to use this effectively. And so it becomes an administrative task at that point. And a lot of clinicians only spend a few minutes just very quickly kind of putting it together because it's seen as, oh, this is just a requirement. We have to do this. Um, and so interestingly enough, one of the most effective ways that we've taught clinicians to make sure they're very patient centered, that they build these relationships and avoid that checklist based approach is like, just don't use paperwork. Like, don't, like, just sit down with someone, just give them a blank index card and talk with them. And you can have your cheat sheet, and we give little like pocket, manuals that are about the size of an index card, to help people with. So here's how to not forget the different pieces of the intervention. But we found that this more tabula rasa approach really encourages and motivates clinicians to engage fully with their patient, as opposed to getting overly focused on filling in the form. Yeah, and
So just
so
giving the
it's
patient the blank index card. So as you're having the conversation, the patient's writing down the various components of the
mhm.
plan. That is just that seems to the clinician's experience of that is different than if you have a worksheet.
That's right. Yeah, yeah. It's been really fascinating to hear from clinicians, as we've trained them. The qualitative feedback that we hear from them are things like, I feel like I'm a human again. I'm not just a robot. Meeting requirements. I'm able to better focus and listen to my patients when I'm not sort of worried about filling out the forms, things like that. And so yeah, it's just one of those. It's almost like a human factors type of thing, where
Mhm.
sometimes we put systems or tools or strategies into place with the intention of improving or having a positive outcome, but sometimes they just don't work as
Mhm.
intended. And I think that is something that has definitely creeped into the profession over the past decade. Of It's just about, yeah, checking the box, instead of taking the time to sit down and say, no, just tell me what's going on and how can I help?
Well, I mean, I went to graduate school, unfortunately, well over a decade ago, and I would say that there was a lot of just check the box then. So I think, in my personal experience, that I think it's been around for quite a while, and so I think that it is an uphill battle to push against
Mm-hmm.
it. So let me ask you a question that you probably get frequently and you might find annoying. So I apologize in advance. But how does crisis response planning, as you all have sort of operationalized it, differ from safety planning?
Yeah. Yeah, they're basically different. I would say they're kind of like different branches on the same evolutionary tree, right? And so I, mentioned before kind of the history of crisis response planning. It kind of started with DBT, and then there was this cognitive behavioral therapy for suicide prevention, and then we kind of plucked the procedure out of there and started testing it independently. And then basically a newer iteration of it was the safety planning approach with the standardized forms. And so it's kind of like just the latest iteration, a different design approach to the same basic concepts. And one of the ways I found it helpful to kind of think about the similarities and differences between them is is the concept of route of delivery. And what I mean by that is, if we think of like medications, there we can administer medications in different ways, one of which is through oral tablets, something like that. But you could also do an intravenous or intramuscular administration. And sometimes those different routes of administration can lead to very different
Mm-hmm.
outcomes. So, like painkillers, for example, is a very obvious example of that. And so I kind of feel like that's, in some respects, how CRP and safety planning are similar and different, in that the ingredients are very similar, but oftentimes the route of delivery is different, because handing a piece of paper to someone to fill out is very different from saying, let's spend some time working through this together and we're going to come up with a customized plan as a collaborative team.
Mhm. So jumping to something different but very related is means restriction counseling. So could you sort of give a 30,000-foot view of means restriction counseling?
Yeah, so there's I think the way that I found it um, kind of helpful to think about the role of things like means restriction, and then there's the counseling process, which is designed to encourage means restriction. And there's, in essence, there are two ways that we can potentially prevent suicide. One of which is to stop people from attempting suicide. Idea being that you have to make a suicide attempt in order to die by suicide. And so if we can change the decision to attempt or not attempt, then we can eliminate or reduce fatal outcomes of that behavior. But there's a second way to prevent suicide, which is to help people survive their suicide attempts. Um, and I think the second approach is actually really important and has been largely, I think, underappreciated by mental health professionals as well as suicide prevention advocates as a whole, because we've been so focused on let's motivate people or try to convince them to not try to kill themselves. Um, but the reality is, despite our best efforts, there will be some people who make suicide attempts anyway, whether because they never came in to receive the intervention from us, or they did and the intervention just wasn't potent enough, or something like that. And so, what this means is we need a backup plan, and the backup plan is to help people survive their suicide attempts. And it's something that I don't, at least when I first pointed out to people, they're kind of confused by it, because they're like, wait a minute, you're saying we shouldn't try to stop people from trying to kill themselves? Like, oh, no, we should. I'm just saying we do need a backup plan, that we need seatbelts, right? Seatbelts won't stop you from getting into a car crash, but if you're in a car crash, the seatbelt can save your life. It helps you survive. And that's where like means restriction and means safety comes in, because if people do not have easy, convenient access to highly lethal, highly dangerous methods for attempting suicide, then it's harder for them to die as a result. And so they may still have attempted suicide, but they wake up afterwards, or they, have some sort of an effect, and then they move on with their lives. And that is still suicide prevention. So it's basically a harm reduction model. And a big piece of that within the clinical space is having conversations with our patients around their access to the most lethal methods for attempting suicide, and how can we place time and distance between people and those methods when an acute crisis occurs, so that they're much more likely to survive those moments.
And so when it comes to, because you've written a lot about uh, like the process of means restriction counseling, and particularly, at least as I've read it, sort of emphasizing how that process can unfold in a way that patients will be receptive to it.
Mm-hmm.
I think that's
Yeah.
something be super helpful for you to sort of chat about a bit here.
Yeah, so we advocate for a motivational interviewing based approach to these conversations. And the reason for that is, of course, motivational interviewing is, pretty much 100% about changing a person's motivation to either stop certain behaviors or engage in alternative behaviors. And part of the philosophy underlying motivational interviewing is that people have to perceive that change is important, right? So doing things in a different way is personally relevant to me. And then they also have to feel as though they can do it. So they have to feel capable, or have a sense of self efficacy. And so, as it relates to those two aspects of motivation, oftentimes people have reasons to not change their behavior or to keep things the same way. And as this applies to means safety counseling, we found that there are oftentimes strong motivations to maintain access to highly lethal means of suicide. The clearest example and a big focus of my work in the United States is firearm access, which arguably it's not a uniquely American problem, but it's very, very disproportionately a United States problem owing to our laws around gun ownership and cultures around that. And so oftentimes there is a lot of reluctance for patients who have access to firearms to lock them up or otherwise limit their access because are concerned about being able to protect themselves and their families. In the case of like a home invasion or something like that, they feel like they have a right to firearm access. And so we really had to learn how to kind of navigate those issues. I found that there's similar dynamics at play for patients who are contemplating other methods. So medication access is another very common issue where for some people access to medication is important for their health, right? So locking up of their meds if they have a chronic medical condition is, not going to necessarily be good for them. But then there are other times where there's a psychological attachment to those methods, where the removal of the medications or the ligatures or the knives or the razors, whatever the case may be, is seen as sort of like a threat in the sense that a primary motivator of suicide is the desire to escape uncomfortable, aversive, punishing life circumstances or states of mind. And so for many people, the thought of, I have an eject button where if things get too bad, I just put this into place, that can actually help them to manage their emotional distress
Mhm.
because they feel like they have the option. And so if you take that away from them, that can be very dysphoria inducing because it's like, well, I don't have an exit strategy, and what am I going to do? You're like sort of condemning me to suffer, and so we have to, even in those circumstances, then navigate these conversations of what are the benefits and the drawbacks of changing how much access or how readily convenient these different methods are for you, and so the motivational interviewing based approach we found is very successful because it really is about embracing where a person is at and acknowledging that there actually are legitimate reasons to maintain access to those methods and there are legitimate reasons to not. And we try to help guide the patient to a place where they are the ones who are saying, I want to voluntarily reduce my access to these methods because it's in my best interest, it's consistent with my values, and so on.
Thanks so much for watching. If you enjoyed this conversation, don't forget to like and subscribe, and be sure to check out the second part of this conversation. Until next time.